Welcome, everyone. Today, we have the privilege of speaking with Dr. Mikhail Kosiborod, a renowned cardiologist and researcher whose latest set of studies shed new light on the treatment of heart disease with preserved ejection fraction, especially in women with obesity, and also looking at it in different ways around how we measure heart failure. And this is part of his STEP-HF program. Mikhail, thanks for joining us today. Before we dive in, can you just share with the audience a little bit about why these studies are game changers in the field of cardiovascular health?
Well, thanks, Harlan, and it's always a pleasure to be with you. Just as a backdrop for why we did the program, which had two trials in STEP-HFpEF and STEP-HFpEF diabetes, we've seen this remarkable change in epidemiology of heart failure in the past 20 years. You know, when I was a cardiology fellow at Yale, I relatively rarely saw a patient with heart failure who had preserved ejection fraction. Almost everyone with heart failure had reduced EF. And in fact, most of these patients had heart failure with reduced EF as a complication of coronary artery disease. That has changed dramatically in the past 20 years. Now, majority of people with heart failure have heart failure with preserved ejection fraction. And of course, anytime you see the dramatic shift in epidemiology, you got to ask, what's driving it? And, the hypothesis behind this program was that we saw that this shift in epidemiology was happening in parallel with a dramatic rise in the prevalence of obesity. And we were seeing that about 80% of all people with HFpEF in the US living with overweight or obesity. And so we said, it's probably not an accident. And in fact, there was a growing body of evidence explaining exactly how obesity can lead to heart failure, development and progression. So we said, we believe that obesity is actually what's causing heart failure in many of these patients. In order to prove that hypothesis, we designed this interventional trial program in people with obesity-related HFpEF, STEP-HFpEF in people with obesity-related HFpEF without diabetes, and a STEP-HFpEF diabetes trial that looked at the same patient population with concomitant type 2 diabetes. And what ultimately the program demonstrated was that, in fact, the hypothesis was correct. That treatment with semaglutide 2.4 milligrams once weekly, which is a potent GLP-1 receptor agonist, as compared with placebo, didn't just lead to a clinically meaningful weight loss in both of these trials, but resulted in very large improvement in heart failure-related symptoms and physical limitations, as well as exercise function, reduced inflammation, reduced markers of congestion, and actually even showed, while these trials were not outcome trials, showed a pretty compelling signal towards fewer heart failure events, while being very well tolerated. Yeah.
And for people listening, first of all, you're very humble. I mean, you were prescient. I mean, you were the one who actually had this idea that we could take these drugs, which are being focused on weight loss and obesity, and treating obesity as a disease, and thinking that this actually might play an important role in an area where we have been frustrated for years, unable to really make progress with very important interventions that would improve people's lives. And I just think it was so amazing that, against the stream, against headwinds of people saying to you that, this isn't really the place to look. No, all the drugs fail in this area. Why would we do more? You were able to persevere, and push forward this program. I know with a big team, but really, you deserve all the credit to push this forward. And I want to just emphasize what you said. In an area where we have been unable to make much progress, you were able to identify a drug that improved heart failure-related symptoms and physical limitations, exercise function, systemic inflammation, the peptides reflecting the underlying physiology. It was a big, big, big winner. And anyway, I just want to make sure that we put an exclamation mark on really what you were able to do in coming up with this idea and now seeing this program through. And you're still at the beginning of teaching us about all the ways, but this is going to change the paradigm. This is why it's game changing. I wonder if you can tell us a little bit about these papers that have been coming out at the ADA and that we're going to be reading about from the STEP-HF program. I mean, can you just say what's new in what's coming out?
Yes, and just to briefly comment, first of all, thank you very much, Harlan, for your kind words. And yes, it's always a team effort. It takes teams of people to make something like that possible. But I think it is paradigm changing because for the first time, we have a highly effective treatment in this patient population, which, so far we just have one class of GLP-2 inhibitors, which do reduce hospitalizations and have modest effects on improving symptoms and physical limitations. But these are the largest treatment benefits on these outcomes that we've seen with really any intervention in this patient group. And the change in paradigm is really no longer thinking about obesity as a comorbidity in this patient population that we kind of pay lip service to and acknowledge, but don't really do anything about. Now, obesity is a key driver of development and progression of the step of heart failure, and it should absolutely be the target for intervention. Puts cardiologists in particular, in the driver's seat to say this is something we must address if we're going to treat this disease effectively. Now, about these papers, I think one of the key questions that has been asked since we've presented and published these main analysis from both trials has been, well, is this weight loss or is it the drug? In other words, is it just simple mechanical unloading? So do people who have obesity and heart failure just feel better because they've lost weight, right? They have less weight to carry around. Or is the drug actually doing something fundamentally critical in the pathobiology, improving the pathobiology of heart failure? Is it a disease-modifying drug in heart failure? Is the best I can put it. And so there have been a number of papers that we've published since the main results, and probably one of the most important was actually the ones that came out at the ACC Heart Failure Congress on the NT-proBNP effects. But there are multiple lines of evidence pointing towards the fact that it's more than weight loss. In fact, people who have more severe heart failure, as measured by various parameters, actually have even greater improvement in their heart failure-related symptoms and physical limitations-wise. They lose about the same amount of weight as everybody else. And the effects on NT-proBNP, which are somewhat counterintuitive, like typically we would expect natriuretic peptides to go up when people lose weight. That's what happens with lifestyle-mediated weight loss. But in fact, they go down with semaglutide, they go down significantly. So multiple lines of evidence essentially decoupling, at least to some extent, the benefits, the heart failure benefits that we see in a trial from the weight loss itself. So part of it is probably weight loss, but clearly part of it is the direct effect of the drug that is purely or clearly disease modifying. So that's kind of what we've done so far. Now, for these additional analysis that are at the ADA, there are really a couple of them to talk about, and I think both of them are independently important. One was looking at the shift in NYHA class with semaglutide versus placebo, which we measured at multiple time points. And of course, the primary endpoint was Kansas Cardiomyopathy Questionnaire, which is the gold standard of assessing heart failure-related symptoms and physical limitations from a patient perspective, right? It's a patient-reported outcome. But we also measured NYHA class, which is what clinicians typically do. And we know it's not a perfect tool, but we use it all the time. And we know it's highly prognostically important. And in fact, in some trials with some interventions, patients with more advanced heart failure, such as those with a higher NYHA class, don't respond to treatments as well as if they're less severe, if they have less severe heart failure and lower NYHA class. So that was an important analysis. And it now is looking at objective assessment of patient's functional status by a clinician rather than a patient reported or looking at from a patient standpoint. So I think it's an additional important facet. And then the second one is actually looking at the outcomes by sex. So evaluating semaglutide versus placebo effects in men and women. And I think that's really important as well, because we've seen before differential effects in men and women, especially in HFpEF. And there are also important effects, differential effects on weight loss with GLP-1 receptor agonists between men and women that had previously been observed in the obesity trials, not necessarily in heart failure trials. So I think both of these are important for different reasons.
No, I think it's terrific. And in this idea in the sex analysis, women lose more weight, but get about the same benefit with regard to the drug, again, showing this, that the drug is probably working directly on the heart or in some ways the physiology, like you said. And I think these represent a real breakthrough in our field. So just let me frame this for you. So what are the clinical implications of the STEP-HFpEF program? What should practicing clinicians be thinking about this? Because these drugs remain underutilized. And yet we've got lots of people suffering from heart failure with preserved ejection fraction and obesity. I mean, what do you think the clinical implications are?
Yeah, so just briefly, first off, kind of a key messages here. So on the analysis in men and women, as you already pointed out, essentially the bottom line is women lose more weight than men do by quite a bit. But there is the effects of semaglutide on symptoms and physical limitations due to heart failure essentially identical, which again decouples the effects of semaglutide on weight from the heart failure benefits. Yes, some of it probably is due to weight loss, but certainly not everything appears to be due to weight loss, and there are probably disease-modifying effects on heart failure pathobiology that are weight loss independent. On the NYHA class, the key observation essentially is that even though we know NYHA class is an imperfect tool, and it's especially imperfect in terms of tracking the functional status over time, because clinicians are pretty reluctant to change NYHA class, even if the patients feel a lot better. But yeah, with that inherent limitation, we actually saw pretty substantial benefits of semaglutide, with a lot more people, more than double the odds of patients shifting down in NYHA class with semaglutide versus placebo, and roughly about two-thirds less odds or lower odds of worsening NYHA class with semaglutide versus placebo. So very, very substantial, large effects on NYHA class, actually much larger than what we see with some of the other heart failure treatments, including SGLT2 inhibition in this patient population that had been previously reported. Now, in terms of clinical implications, I mean, I think, as I kind of mentioned before, this can be a real game changer in how we treat at least this type of HFpEF, the obesity-related HFpEF, which again in the US is a majority of the patient population. Yes, it is true that these trials do not offer definitive evidence that we lower heart failure events or cardiovascular death. They show very large benefits on a very important outcome, which is symptoms, functional limitations, quality of life, and a number of other things that you already mentioned. But that's a critical, in fact, for patients with HFpEF, that's actually what they say is one of the most important, if not the most important outcome for them. For many patients, more important than survival. So I think if we're truly patient-centric, we've got to really pay close attention to this. We now have 2 independent trials showing very, very, very consistent results. And I think it should change clinical practice. I think it'll be very difficult to manage obesity-related HFpEF without targeting obesity itself, which is a root cause in many of these patients.
So, Mikhail, what further research is needed now? What's on the horizon with regard to trials and upcoming studies?
Well, there is a lot going on. There is the good news in this space of understanding the relationship of obesity and cardiovascular complications, and specifically heart failure, is that there are a lot of additional anti-obesity agents being developed, both incretin-based and others. And so there's going to be a lot of work in this space coming up. Probably the most immediate one is a trial called Summit, which is looking at tirzepatide, a dual GLP-1 GIP agonist in patients with obesity-related HFpEF. And that trial is actually, the protocol was just amended recently, and one of the primary endpoints is actually going to be clinical events, the cardiovascular death and worsening heart failure events. But I would predict that given all of the developments that's happening in anti-obesity space, there are going to be additional trials in heart failure, certainly heart failure with preserved ejection fraction, and there will be larger outcome trials that really will help us understand, in addition to the effects on patient-related symptoms and patient-reported symptoms and physical limitations, also the effects in a definitive way on clinical events. But I think, the real, as you mentioned before, the real value of the STEP-HFpEF program, in addition to all the insightful data that we got, is really changing the conversation about obesity as a comorbidity versus obesity as a key driver of progression development of heart failure in this patient population. And so when all said and done, I suspect the clinical science, better understanding the disease process and the treatments for the disease process, is going to be entirely different.
Mikhail, thanks so much for sharing these really valuable insights. Your program and the team is doing amazing work, really changing the face of our ability to improve the outcomes for these patients, and paving the way for more personalized and effective treatment strategies for these individuals, as we understand particularly who's benefiting and how this is fitting into clinical practice. We look forward to seeing more research in the future. We're proud to publish this stuff in JACC. We know it's going to help all clinicians around the world. Thanks so much for your time and contributions.
Well, we are honored to have it published in JACC, Harlan, and thanks so much for your time, and always a pleasure.